Okay, I see a red button.
Yep.
So we are in business. Good morning. Welcome to the April PCEP. It's a discussion today of pathophysiology, recognition, and treatment of shock in all its various and glorious forms. Simplistically, shock is simply cellular and tissue hypoxia, but it can be due to a number of things, such as reduced oxygen delivery, increased oxygen consumption, inadequate oxygen utilization. An example would be someone who has cyanide poisoning is having inadequate oxygen utilization, and so they go into shock because their oxygen utilization is blocked at the cellular level. Most commonly, shock occurs in our experience due to circulatory failure, which then essentially then means that you're not taking adequate, you're not getting oxygen to the tissue, and so the tissue goes into, it has reduced perfusion. A secondary thing, which we always have to consider, is that the other thing is, besides delivering oxygen and substrate to the tissue, the problem with shock is you're not taking away the garbage. So you're having a garbage issue.
Thank you. I think I have to do this to get credit with AMR.
Can someone mute themselves, please? Now, often we consider shock just an undifferentiated state of shock, but we don't recognize the cause is clear for the shock. Shock is initially reversible, but rapidly becomes irreversible and results in multi-organ failure. When a patient presents an undifferentiated shock, the clinician should initiate therapy while rapidly identifying the etiology so the definitive therapy can be given. So, for example, shock can occur because of failure of cardiac output, basically due to either profound bradycardia or profound tachycardia, not sinus tachycardia usually, but a tachycardia above so that there's not enough filling time for the heart to be able to pump. Then shock can occur if there's inadequate fluid in the vascular system. Shock can also occur if there's a obstruction of the inflow to the heart from due to problems with perhaps tension pneumothorax or cardiac tamponade. Also, then just simply blood loss, blood volume loss. 4 basic types of shock: distributive shock, cardiogenic shock, hypovolemic shock, and obstructive. We'll talk about all those. Now, shock types are not necessarily exclusive. Many patients with circulatory failure have a combination of more than one type of shock. Distributive shock is essentially characterized by severe peripheral vasodilatation, so that your vascular system has expanded to the point where it's basically pooling blood peripheral to the heart, and so it's not getting to the heart to be pumped forward. General causes are sepsis or a systemic inflammatory response syndrome, also neurologic derangements, anaphylaxis, drug and toxin, endocrine problems. Sepsis is a life-threatening organ dysfunction caused by a dysregulated host. Septic shock is a subset of the sepsis, and the mortality rate at septic shock is in the 40 to 50% range. We can identify a septic shock by presence of by the necessity to use vasopressors, and also the presence of activated lactate levels. Now, we don't currently test for lactate levels in the in pre-hospital, but a good substitute for that is the SpCO2, because if you have acidosis present, the host organism is going to be essentially increasing its respiratory rate to blow off CO2 and therefore decrease the acidosis. So it's a marker for this, and it's quite accurate. So this is one of the reasons we're encouraging, especially for sick patients, to not only monitor their O2 saturation, but their SpCO2. Whoops, got to go forward here. Now, SIRS, the systemic inflammatory response system, is an inflammatory response that can be due to sepsis, but it can also be to non-infectious things, such as pancreatitis is commonly associated with a SIRS type of response. Burns can be associated, not acute burns, but burns over a prolonged period of time, just like potassium levels are not affected immediately by the burn, but you'll get significant potassium shifts within 24 to 72 hours after a major burn. Significant blunt trauma and crush injury can cause inflammatory response similar to that from a burn. Amniotic fluid embolisms, air fat embolisms, thing called systemic capillary leak syndrome, which is not something we would diagnose in the pre-hospital case. And also after successful ROSC, after cardiac arrest or myocardial infarction, they often develop shock on an inflammatory response basis. Also, distributive shock can occur with neurogenic shock. Hypotension is common with severe traumatic brain injury and spinal cord injury, and this is basically due to decreased systemic vascular response and altered vagal tone. Blood loss and myocardial depression also contributes to shock in this population. Anaphylactic shock is severe IgE-mediated allergic reactions, most commonly to bee stings, food and drug allergies. You get shock, bronchospasm, increased airway resistance. Drug and toxin-induced shock, drug overdose, long-acting narcotics are associated with a distributive shock due to peripheral vasodilatation. Snake and insect bites often associated with a distributive shock. Heavy metal poisoning, arsenic, iron, thallium, we seldom see, but it's a terrible shock syndrome in children who ingest iron, have iron overdose. It's extremely difficult to manage them in shock. And then there's the syndrome called toxic shock syndrome, which we don't see much of anymore, although it does occur, and it's basically toxin-induced shock, usually caused by gram-negative, but also can be caused by gram-positive organisms. Addisonian crisis and mixed edema, we'll talk more about this in the past, but Addisonian crisis occurs not infrequently. Okay. Now, switching gears to cardiogenic shock. Cardiogenic shock is caused by cardiac pump failure. It results in reduced cardiac output. Causes can be directly cardiomyopathic. Generally speaking, an MI involving 40% of the left ventricular myocardium reduces the heart's ability to maintain the systemic vascular pressure. But an MI of any size with severe ischemia of the heart due to multi-vessel cardiac coronary artery disease will cause shock. So you don't have to have a big MI if you've got a sick heart to start with. Severe right ventricular infarction, in this case, the right ventricle is unable to pump blood forward to the pulmonary system because it's been weakened. It's intrinsically a weak, low-pressure system anyway. And so if you markedly decrease your right ventricle, you basically starve the left ventricle for blood because you're not pumping blood into the lung. The other thing is with reduced flow through the pulmonary system, you're getting reduced oxygen carrying capacity of the blood. So when that little bit is pumped forward to the tissues, it's going to be low, relatively low in oxygen, and compound the problem. Following cardiac arrest, we often get stunning of the myocardium. It's very common. I review all the cardiac arrests, ROSCs, and the survivors, and I also review the patients who've had STEMIs for their outcome, and a significant number of them have remarkably reduced left ventricular ejection after their infarct or their cardiac arrest, and they generally improve prior to discharge. But the myocardium stays stunned for a while, and this is why we have in your orders for cardiac arrest, if you get ROSC, one of the things for stabilizing the patient is to manage hypotension if they are hypotense after ROSC. Prolonged ischemia by itself can cause reduced myocardial function, septic shock, and neurogenic shock. So these are not primarily cardiac, but secondary to septic shock or neurogenic shock, you can get myocardial depression. And of course, myocarditis and in usually generally a viral infection of the heart will cause hypotension. Now, you can get cardiogenic shock based on arrhythmias. Both atrial and ventricular dysrhythms can induce hypotension because the cardiac output is severely compromised. If number one, if you have marked bradycardia, and number two, if you have a ventricular tachycardia or a complete heart block. Or excuse me, if you have ventricular tachycardia, if you have supraventricular tachycardia, particularly in a heart that's already got some coronary artery disease. You get mechanical causes of cardiogenic shock from valvular insufficiency, papillary muscles, the little parachutes that retain the mitral valve, particularly so that it doesn't flop back into the atrium, allowing blood to flow backward into the left atrium. You rupture a papillary muscle, and you can go into a significant portion of the cardiac output is then redirected back into the pulmonary system, which creates pulmonary edema often, and also reduces the cardiac output going forward out of the aorta. Ventricular septal defects, allowing a left to right shunt, will also decrease the amount of cardiac output, and septum or ventricular rupture obviously will significantly decrease the cardiac output. Now, hypovolemic shock is reduced intravascular volume, which gives you reduced preload, which in turn reduces cardiac output. And the most very common would be hemorrhagic shock. So this is where our trauma friends come into play. This is reduced intravascular volume from blood loss. Can be blunt and penetrating trauma, most commonly. GI bleeding, I've had some personal experience with that. Not the variceal hemorrhages, but bleeding from diverticula and peptic ulcers also can cause. So anyone with a significant GI bleed can have can go into shock from simple blood loss. Other hemorrhagic causes: postpartum, excessive bleeding postpartum, usually due to atony of the uterus, vaginal bleeding, etc. Non-hemorrhagic shock, though, is as interesting as hypovolemic. Non-hemorrhagic shock is reduced intravascular volume from fluid loss other than blood loss. So you get volume depletion from loss of sodium and water. GI losses, both vomiting and diarrhea, more commonly than in children or in severe GI illnesses such as cholera, things like that. Skin losses, losses from sweating, from evaporation from the skin itself, renal losses due to kidney failure, and third space losses into the extravascular space or body cavity, such as an example would be severe ascites associated with end-stage liver disease. Obstructive shock is due to extracardiac causes of cardiac pump failure, and then associated with poor ventricular output. And these are the, from the pulmonary system itself, you could have a severe pulmonary hypertension or a PE, a pulmonary embolus, which is large enough to stop enough blood flow through the pulmonary system to cause decrease in left ventricular output because it's starving for blood. Pulmonary tricuspid valvular stenosis, so the right ventricle is becomes hypertrophic and tries to force blood through a progressively narrowing opening into the pulmonary system. Net effect is you're essentially running out of blood through the pulmonary system. Mechanical is a decreased preload rather than pump failure itself. So tension pneumothorax, pericardial tamponade, constrictive pericarditis, restrictive cardiomyopathy, and then the abdominal compartment syndrome, where basically you're in all of these things, you're impeding the preload back to the right ventricle. So essentially the heart in general is being starved for blood due to this, due to the mechanical obstruction Combined shock, I mentioned combined shock before, that these are often mixed shocks. Pancreatitis is primarily distributive shock. There's vascular permeability is disrupted, and you get peripheral vasodilatation. So you basically get pooling and sequestering of blood, and you get decreased preload. But there's a hypovolemic component because there's decreased oral intake, insensible losses, usually through vomiting, diarrhea, etc., and perhaps a fever. And then there's a cardiogenic component, inflammatory related myocardial depression. So they have at least 3 or 4 different components that are causing combined shock in the patient, and so it makes it much more difficult to manage. Now, in cardiomyopathy, you get hypovolemic shock, and then also we commonly over-diurese patients who are over-diuresed because they take more of their medication than they have, or their diuretic medication needs change. And then you get cardiogenic shock due to inadequate compensatory tachycardia and or stroke volume, because the cardiomyopathy precludes both the heart from increasing adequately in its heart rate, and also because it's weak, it will affect the stroke volume. Severe traumatic injury, hemorrhagic shock from blood loss, and then a distributive shock from the development of a systemic inflammatory response syndrome. Spinal trauma, you have distributive shock, automatic dysfunction, basically lack of tone of the arteries due to cutting the sympathetic nerves, and also have a relative loss of production of epinephrine and norepinephrine. And then cardiogenic shock from myocardial depression, which occurs along with the shock. A little bit on mechanism of shock. Cellular hypoxia occurs when tissue perfusion is reduced due to decreased oxygen delivery, or increased oxygen consumption, or inadequate oxygen utilization. Then cellular hypoxia results in cell membrane ion pump dysfunction, sodium and potassium pumps, calcium, etc. That then results in intracellular edema, leakage of intracellular contents into the extracellular space, and inadequate regulation of intracellular pH. Unchecked cellular hypoxia progresses systemically, and you get acidosis, endothelial, the outside of the cell dysfunction continues to leak, and the sodium, potassium, calcium pump systems are not working appropriately. This further stimulates inflammatory and anti-inflammatory cascades, everything from kinins to all sorts of, all kinins to including bradykinin produces some histaminic release, etc. So you have this continuing cascade of anti-inflammatory and inflammatory material. Compounding this process then is the further reduction in tissue perfusion, because you have reduced blood flow, particularly if there is extracellular edema, which is reducing blood flow. altogether, it's not a good picture. Now, a couple basic science things, and then we're done with that. The determinants of tissue perfusion and therefore systemic blood pressure are cardiac output and systemic vascular resistance, SVR. So blood pressure equals cardiac output times systemic vascular resistance. Cardiac output is the product of heart rate and stroke volume. So cardiac output equals heart rate times the stroke volume. The stroke volume is determined by three basic factors: preload, the blood coming to the heart; myocardial contractility, which is determined by this, how well the myocardium can contract, and what its upper and lower limits are, and afterload, or basically the resistance which it has to pump against, which the heart. And when we're talking about systemic and stroke volume, you're really talking about the left ventricle only. Now, the right ventricle, in a perfect world, the right ventricle pumps the same amount of volume under a different pressure as the left ventricle pumps. The same volume occurs, but with obstructive things, we have other problems now. Systemic vascular resistance is governed by the length of the vessel diameter, which is then determined by the vessel tone. So when you have adequate normal systemic sympathetic stimulation, the vessel is at a certain size. When you increase that sympathetic stimulation, like with norepinephrine or with epinephrine itself, you get decrease in the size, you get contraction of the muscle, so you get decrease in the size of the vessel diameter, which increases the resistance. And so when you lose that sympathetic tone, you get dilatation, which decreases the vascular resistance. And then blood viscosity is also a determinant of the systemic vascular resistance, because thicker blood, let's say if you have polycythemia and you have instead of a normal hematocrit of around 40 to 42 for the male, you have a hematocrit in the neighborhood of 52 to 55. You end up with increased viscosity. And blood moves very sluggishly and slowly because it has just increased resistance. There's so much solid material in there called red cells. Processes that change any of these physiologic parameters can ultimately result in hypotension and shock. So if you decrease the stroke volume because preload is dropped, then you end up with shock. If you decrease the myocardial contractility because the heart is stunned, you end up with shock. Now, stages of shock. In the quote pre-shock, which is where we'd like to start treating patients, so you have to have significant thought process going that you think the patient has a good reason to possibly go into shock. There's compensatory responses to diminished tissue perfusion, but it's generally very minimal. The first thing is probably mild tachycardia and peripheral vasoconstriction, which is why we ask you to check when you're considering shock in a trauma case or in a person who's sick and might be septic. We have you check for for skin signs such as decreased, which indicate decreased perfusion. So you have increased capillary fill time. This is a sign often of peripheral vasoconstriction, and maybe one of the earliest signs, along with mild tachycardia. Tachycardia always has to be explained. Early management of pre-shock may prevent the progression. This is why we would like to start fluid challenges early, and if they reverse, and if the patient gets better, we call this shock, basically pre-shock that can be treated. Now, shock is where you have signs and symptoms of true organ dysfunction. So symptomatic tachycardia, dyspnea, and tachypnea, restlessness. Restlessness is basically due to increased endogenous epinephrine and norepinephrine. Diaphoresis, metabolic acidosis. Remember, that goes along with their dyspnea and their tachypnea. Hypotension, which generally doesn't usually occur, at least in the shock in trauma, until you've at least have a level 2 bleed. Oliguria, hopefully you're not, so they have decreased urinary output. Hopefully you're not with the patient long enough to know that they're going to have decreased oliguria. And cool, clammy skin from the increased production of endogenous epinephrine, norepinephrine, which causes that vasoconstriction, which gave you the decrease in, it gives you the skin signs of cool, clammy skin and the prolonged capillary refill. End organ dysfunction, you get the ultimate problem with shock is that ultimately you get irreversible organ damage and multi-organ failure. Generally, almost all of the patients who are in shock states post ROSC, for example, will have acute kidney failure, some evidence of shock, and some evidence of acute liver injury. But often they can be, by treating the shock appropriately, they will recover from those things. But when you get irreversible organ damage, multi-organ failure, that ultimately results in death. Now, let's go on to a little bit more actual identification, treatment of the kinds of shock that we see commonly in the field. And I'm here to tell you, we see more cases of sepsis in the field now than we do myocardial infarction or stroke. So sepsis is extremely prevalent, and it's very, very common, particularly in older population groups. This was a 10-year trend in septic shock being reported back in 16 that over the period of about a 10-year period between 2005 to 2014, rates of septic shock increased from 12 per 1,000 hospital admissions to about 18 or 19 per 1,000 hospital admissions. Now, that may have been twofold. Either or three or more things may have been possible. Either we're better at identifying shock, and there was a push to identify shock and systemic inflammatory response syndrome during that time period. So it might just have been better diagnosis, more awareness. It might also have been because the population is aging, and it might also have been because there are there's simply more cases of shock, septic shock. The mortality, however, decreased from 55 to 51%, even though the numbers increased, because apparently let's hope we're getting better at treating shock. Risk factors for septic shock. No, this isn't. An intensive care unit admission. That means any time in the past. That means that these are people that are previously sick and are not perfectly healthy adult, persons, and would, and therefore are more likely to become sick again. Bacteremia. This is why we take blood cultures of people who we think are in shock. Advanced age, over 65 years of age. Everything seems to happen to us over age 65. Patients who are immunosuppressed. So patients with HIV, patients with who are on immunosuppressive agents, including steroids, diabetes and obesity, cancer patients, probably because there's some tissue immunosuppression, community-acquired pneumonias, very common. So, and of course, most of the people who died from COVID went on to develop a pneumonia, respiratory thing, and or a shock syndrome and a systemic inflammatory response syndrome, so that sometimes it involves cardiac, sometimes it involves just the lungs, sometimes it involves the GI tract, but in general, ultimately, they died of shock and respiratory failure or cardiac failure. Previous hospitalizations, once again, just like the intensive care unit admission, that means that they're not healthy adults. And genetic factors. Symptoms and signs of septic shock are specific, if you have symptoms, signs specific to an infectious source. So if you have a high suspicion the person has a urinary tract infection from whatever, or if you have suspicion that they have a severe cough, so you think, and they have rales and rhonchi and a fever, you think, well, they probably have pneumonia. If they have a viral diarrheic syndrome, such as occurs with norovirus, then if they have hypotension, blood pressure less than 90 or MAP less than 70, temperature greater than 38 or less than 36, so it's in the 96 to below 96, 97, and above 102. So to be septic, you can either have a fever or you can be hypothermic. Heart rate greater than 90, tachypnea greater than 20, i.e. they're acidotic, they're blowing off CO2 as a compensatory mechanism. And then signs of endo-organ perfusion, which would include decreased capillary refill, warm, generally flushed skin, cyanosis, mottling. Other signs of hypoperfusion, one of the most important is altered mental status. I know you guys are seeing, you get called to care facilities all the time because the patient doesn't seem to be in his or her usual mental status. And of course, when you ask them, they say, well, we knew them to be they were last okay a couple days ago. Obtundation, restlessness, oliguria, anuria. You can have absent bowel signs or an apparent ileus, which is often associated with hypoperfusion, but that's something we'll be looking for more in the hospital. Now, we don't really use the Q-SOFA much anymore, which is but it's a good key to indicate the likelihood that this is really a sick person. So if the respiratory rate is over 22, if they have altered mentation, and if their systemic blood pressure is less than 100, those are associated with sepsis. Those are likely to be people with poor outcomes, so they need to be. It's good hints to go ahead and treat them aggressively. Now, septic shock. You could say this is definitely septic shock if you require blood pressures to maintain a MAP greater than 65, and in the hospital we'll get a lactate level. But the vasopressors are given after you've given a decent trial of fluid. Now, cardiogenic shock, acute myocardial infarction is the most common cause of cardiogenic shock. With rates with cardiogenic shock after an MI that would occur to mortality rates are about 50% in some studies. I think we're a little bit better than that. Pathophysiology is simply failure of the left or right ventricle. Now, etiology of cardiogenic shock, left ventricular dysfunction due to an MI may result from any infarct, especially if they've had a previous MI, but multivessel coronary artery disease, remember, can result in shock no matter what the size of the infarct is. So they can have a little tiny infarct, but if they've got a generally ischemic heart due to coronary artery disease, multivessel disease, they could develop shock quite easily. With mitral valve regurgitation, which can be an effect of an MI due to ruptured papillary muscles, or you can have interventricular septal rupture or cardiac tamponade from a left ventricular rupture. Now, in this case, cardiac tamponade decreases stops the preload again. Risk factors for cardiogenic shock: older age, anterior MI, history of hypertension, shows probably they got some underlying cardiovascular disease, diabetes mellitus, multivessel coronary artery disease, a prior MI with congestive failure, and systolic blood pressure less than 120, heart rate greater than 90, and or a left bundle branch block. These are all risk factors for cardiogenic shock. Clinical signs of hypoperfusion in cardiogenic shock include hypotension, oliguria, altered mental status, cold, clammy skin, may present with respiratory distress due to pulmonary congestion, congestive heart failure. Physical exam, hypotension, tachycardia, tachypnea. You may find distended neck veins, cool skin, diaphoresis, rales, gallop rhythm, etc. Now, pulmonary embolus is an obstruction of pulmonary artery by thrombus, tumor, etc. But generally speaking, it's from a thrombus. And hemodynamically, you can have a stable pulmonary embolus, just symptomatic, but otherwise stable hemodynamically, or an unstable pulmonary embolus results in hypotension. And this is generally due then to obstructive shock, which the pulmonary embolus affects the flow of blood through the and obstructs the flow of blood through the pulmonary system. Basically, it's an obstructive shock. Generally speaking, pulmonary emboli occur from venous stasis, endothelial injury, and/or a hypercoagulable state. They all occur together. So the risk factors are exactly similar to those for the risks of venous thromboembolism, which are listed on that side, but include malignancy, surgery, especially orthopedic surgery with, and especially with immobilization in a cast of a lower extremity, trauma, pregnancy, oral contraceptives, hormone replacement therapy, particularly estrogens, heart failure, immobilization of any sort, whether you're just laying in bed, older age group, obesity, severe liver disease, etc. You can also have inherent propensities to the hypercoagulable state, so thrombophilia, and these patients, so almost everybody who develops a thromboembolism or who develops a pulmonary embolus should be genetically tested to see if they have a genetic propensity toward hypercoagulation, and then beyond probably lifelong anticoagulants. Most emboli arise from the lower extremity proximal veins, so the large veins in the thigh and the pelvis. Now, however, there are, particularly after pregnancy and pelvic surgery, you can get pelvic vein thrombosis as well. Most thrombi develop wherever there's decreased flow, so either at the venous valve cuffs or bifurcations in the vein. Infarction of the lung occurs in about 10% of patients, and those typically present with pleuritic chest pain and hemoptysis. But abnormal gas exchange is generally the rule. It affects what is called the ventilation to perfusion ratio, showing that there's obstructed areas of the lungs that are being ventilated but not perfused. Inflammation results in dysfunction of the surfactant of the lung, so decrease in oxygen exchange at the alveolus, and then hypotension due to diminished systemic vascular or due to stroke volume and cardiac output is decreased due to the obstructive component. Most common clinical presentations are dyspnea, chest pain, which is pleuritic in nature, cough, along with symptoms of a DVT, generally calf or thigh pain. Orthopnea means they get short of breath when they change position. Wheezing and hemoptysis, but many pulmonary emboli present with only dyspnea. Now, hemorrhagic shock, we used to have, and we still do, like to talk about 4 classes of hemorrhage. The volume loss up to 15%, which is class 1, which is generally no change in blood pressure, pulse pressure, might have a slight increase in heart rate, might have a slight bit of increase in their capillary refill. Class 2 hemorrhage, which is 15 to 30% of blood volume, and remember you're using about, that's losing up to about 1,200 cc's of blood. Heart rate increases moderately. Respiratory rate rises to about 20 to 24. Decreased pulse pressure. Your systolic blood pressure doesn't change much. Skin may be cool and clammy. Once again, the effect of increased epinephrine, norepinephrine release. Class 3 hemorrhage, loss of 30 to 40%, which is about 1,800 to 2,000 cc's for a normal person. Systolic blood pressure then is less than 90. Mental status changes. Heart rate's above 120, generally thready. Respiratory rate is elevated. Urine output's diminished. Capillary refill markedly delayed. Class 4 hemorrhage, 40%. So you're looking at close to half your blood volume. And obviously those are in profound shock with all the things you can find in shock. Now, if we can start managing people with class 1 and class 2 hemorrhage appropriately, then we significantly decrease. By the time you get to class 4 hemorrhage, this is a lot of work to try to get someone out of it, and ultimately it will be irreversible. Management of hemorrhagic shock, obviously, you guys are experts on that. Direct pressure, tourniquet, wound packing. I've seen there's a couple of new items out there for wound packing now, especially to do the packing at the junctional areas like in the groin, etc., which are hard to do packing and hard to do external control. IV fluid resuscitation. You only start resuscitation, in other words, fluid challenges, if the patient's hypotensive, and then only until blood's available. Over and over, we've proven that the best treatment for hemorrhagic shock is blood, replacement of blood, and actually whole blood is better than any other kind of blood. So blood products, but because whole blood is not always very available, we use packed red cells and replacements with massive transfusion protocol. We'll be using addition of fresh frozen plasmas and other clotting factors. And then, of course, surgical advantage of the treatment of traumatic hemorrhagic shock is generally surgery. Fluid resuscitation uses 16 gauge or greater short catheter. Remember, the resistance to flow is due to the length of the vessel or catheter, the diameter of the catheter, and what thickness of the viscosity of the blood you're putting through it. So if you're doing fluid resuscitation, use a short, bigger catheter. You get much quicker installation of fluid. We use isotonic crystalloid, 500 cc bolus. How much is a 500 cc bolus? Well, that's not a lot of, in many respects, that's not a lot of blood. That's not a lot of fluid. 500 cc is basically a little over. It's a big cup or a big can of Coke. We're not recommending you give a can of Coke, but you know what I mean. It's so, I mean, that now, if you have an older person, you might, but not in shock, your goal is to not get the fluid overloaded. So your goal, we're trying to get a systolic blood pressure of at least 90. So we don't even start unless they're hypotensive. And one of the problems with trauma is one of the problems with giving just crystalloid is it dilutes the clotting factor, which makes them bleed more from, not only raises the blood pressure, but it makes them bleed more from where they were injured. So that and so you increase the blood pressure, decrease the clotting factor, you're going to increase bleeding at the site of injury. And also hypothermia occurs with lots of fluid. Now, with neurogenic shock, specifically spinal cord injury, hypotension, bradycardia, you've disrupted the autonomic pathways in the spinal cord. So you basically stop the sympathetic response, the sympathetic stimulation of the blood vessels. You get vasodilatation and decreased vascular resistance then. Also, they may have hemorrhage due to trauma that caused them to have their spinal cord injury. They'll have inflammation if you have any inflammatory component of it, such as if the bowel has been affected, if they've got other tissue crush injury associated with, and then hypoxia from decreasing cardiac output. Management prevents further spinal injury, treat associated hemorrhage, limit ischemic spinal cord injury, maintaining your blood pressure about 85 to 90. And you do that by first a fluid challenge, and then if necessary, to add a vasopressor. And then respiratory complications, if they're having, with their spinal injury, they're having a problem ventilating, then you need to ventilate for them. Anaphylactic shock is systemic hypersensitivity, multi-organ syndrome, release of mediators and mast cell degranulations as an allergic reaction. Hypersensitivity to and cause of death in severe anaphylaxis is generally respiratory arrest with cardiovascular collapse. So you have both a respiratory issue and a cardiovascular collapse. Cardiovascular effects occur due to myocardial ischemia, conduction defects, AV dysrhythms, T-wave abnormalities, and coronary artery vasospasm. You get fluid shifts due to increased vascular permeability, reduced intravascular volume. Tachycardia is initially your initial response, and then bradycardia due to the sympatholytic medications, vagal stimulation, etc. Management of anaphylactic shock would remove the inciting cause if possible, but epinephrine at the earliest abnormality. All the studies show that the problem with severe morbidity and mortality, particularly from anaphylaxis, occurs when we don't get epinephrine appropriately into the person at the earliest opportunity, when we go for the other simple measures and or fail to recognize that this is true anaphylaxis. Also, If the patient's in shock, put them in shock position, lay them down with lower extremities elevated, unless they can't tolerate it for some reason. If they're vomiting, they should be semi-recumbent. Pregnant patients on their left side to avoid the placental compression syndrome. There's an interesting study from the United Kingdom, because I'm not sure how they did it. 4 of the 10 fatalities associated with anaphylaxis were associated with the assumption of putting the patient in an upright or a sitting posture. And I guess this makes perfectly good sense. I can't understand why they were putting them in an upright or sitting posture, but it shows that essentially they develop PEA due to an empty ventricle because they have so much vasodilatation and no intravascular volume. So why would we sit them up? I don't know. Maybe that's something the Brits do. Any rate, they all get supplemental oxygen as well and volume resuscitation as needed. Adrenal crisis is very simply life-threatening adrenal insufficiency, lack of adequate corticosteroids to your normal corticosteroid basically adjusts or helps you to adjust all of your vascular tone, all your sympathetic nervous system, and it's you basically don't do well without it, because the most common signs of adrenal insufficiency are hypotension, shock, loss of consciousness, sodium-potassium imbalance, and relative dehydration. Precipitating factors in causing adrenal crisis are trauma, infections, and other stressors. Well, and Addison's disease is not something we diagnose every day, but there's a lot of people with Addison's disease and adrenal issues in our county. Actually, I reviewed this about 6 or 8 years ago when the state was doing some. The state legislature was interested in some adrenal issues, and the actual people with Addison's disease, which is an inherent loss of adrenal function. In Clark County, there's only about 6 or 8 adults who have true Addison's disease, and of children who are hypoadrenal from congenital thing, there's only maybe a half a dozen as well. But there's a lot of people who have been medically put into a medical adrenal insufficiency by the fact that they're on chronic daily steroids, particularly people who have severe asthma, other severe allergic things that are responsive to steroids. Some people on chemotherapy, some people, at any rate, there's a lot of medical reasons to cause essentially medically induced Addison's disease. And these people are fine as long as they're taking their normal steroids. And the treatment of Addison's disease or hypoadrenalism is oral steroids. But for some reason or another, they either stop taking their medication, or because of increased stresses from other illnesses or trauma, they now become corticosteroid deficient. So suspect it if you if you know they have adrenal insufficiency, how do you know they have it? They tell you, or their family tells you, oh, he takes, he has these things, he has this problem and has to take steroids every day. Or but if they're associated with a trauma or an infection or other stressor, which increases your body's need for corticosteroids, and then they fall behind on it. So the treatment is fluid resuscitation and administering glucocorticoid. And you carry, Solumedrol or Decadron, and that should be given at a good amount, along with fluid resuscitation, and also managing if they have hypoglycemia, which they may well, or hyperkalemia, that can be managed. And sometimes, along with the fluid resuscitation, the glucocorticoids, we may have to put them on a pressor agent for a while. Now, within our pre-hospital, now there's a lot of stuff in here, but our pre-hospital care protocols are pretty well oriented to basic shock. So basic shock treatment by your protocol with hypovolemia, control external bleeding. Give up to 2 liters of isotonic fluid, and our favorite, of course, is a Ringer's lactate. And you give 2 liters of isotonic fluid as rapidly as possible, watching until the blood pressure systolic is 90 to 100 with a MAP of 65, greater than 65, or you develop neck veins distension and or pulmonary ralphs. Now, that would be more likely in older persons, but certainly that's why we give it as we don't give 2 liters at a push. We give a fluid challenge, give a fluid challenge, give a fluid challenge. I always say it's better to give small amounts and give more than to give large amounts and worry about how to get it out of the patient, because you can't. If they're a head injury and they're in shock, they get the fluid challenge, and you're targeting our blood pressure for about 100 systolic with a MAP greater than 65. We like, with a head injury, we like to have their cerebral perfusion up a little bit. Maintain your normal ventilation rate. Target your EtCO2 at 35. Now, for distributive shock treatment, so sepsis, neurogenic, etc. If they're septic, we look at the sepsis protocol that's coming up. Begin a 500 to 1,000 fluid challenge, cc fluid challenge, to maintain your systolic blood pressure of above 100, MAP of 65. Repeat again if they have continued signs of shock and no pulmonary edema. But at that same time, you may want to consider adding norepinephrine, or a pressor. Norepinephrine, we started for the adult 4 micrograms per minute, increasing every 5 minutes in 4 mic per minute increments to a max of 12 mics per minute. Goal, our systolic blood pressure goal, is the same. Now, an alternative to norepinephrine, if you don't have it or don't remember it, would be epinephrine, 2 to 10 mics per minute IV or IO. Now, I would prefer myself epinephrine if the patient is in the shock position. Ordinarily when you start shock, your heart rate is up, but your heart rate will ultimately decline and you can get a bradycardia. So if they're bradycardic, I would put an epinephrine drip on them in preference to a norepi drip, because it'll drive heart rate better. Now, your sepsis protocol, Universal patient care, maintain oxygen saturation above 95. Known or suspected infection with 2 or more of the following gives you sepsis, septic shock. Temperature greater than 38 or less than 36 centigrade. So below 96, above 100.1. Respiratory rate greater than 20 breaths per minute. Heart rate greater than 100 beats per minute. EtCO2 less than or equal to 25. So they're acidotic. If you have 2 of these and your systolic blood pressure is 90 or less, or altered mental status, this is a septic shock alert. Give up to 2 liters of fluid. Maintain your MAP above 65, or stop if neck vein distension develops, pulmonary valves develop. If they're not responding to fluid, once again, norepinephrine, and an alternative is epinephrine. If the patient is normotensive and not altered, in other words, they don't have any of those major symptoms, transport non-emergent, but tell the hospital that this is possible sepsis. So if their temperature's up, their respiratory rate's up, their heart rate is up, and even if their EtCO2 is up or low, and they don't have a low blood pressure, and they're perfectly fine mental status, then they're just a suspect for sepsis. Cardiogenic shock due to a STEMI cardiomyopathy. Follow your dysrhythm protocols and then give 250 to 500 cc fluid challenge. So we're going to give a smaller fluid challenge because we're worried that with the cardiomyopathy or a STEMI that they may go more rapidly into congestive heart failure. So give the fluid challenge. Once again, you're maintaining your blood pressure of 90 with a MAP of greater than 65. Repeat your fluid challenge if they have continued signs of shock and no pulmonary edema. And then if they're not responding, if they're still in shock, despite their 1,000 cc's of fluid, I would then start out with either a norepi drip or a epi drip, depending once again on their blood pressure or their heart rate rather. Now, on this known hypoadrenal state, so a person who's you suspect their shock may be due to their Addison-like illness because they're on chronic steroids, they have a medical alerts tag, or their parent or caregiver says they have low adrenal output. Fluid challenge, Solumedrol 125 to 250 IV, and an alternative would be Decadron 10 milligram IV IM. You could even give it PO if they're able to take fluids, but if they're in shock, they're probably nauseated and won't be able to take an oral. If despite the Solumedrol and the fluid challenge, they still remain shocky, I would not hesitate to start them on a pressor agent. Now, for pediatric patients, pediatric fluid challenge is 20 mils per kilogram. Repeat it. You can repeat it once, appropriate and you're using the appropriate you're aiming for the appropriate blood pressure for the age. It's uncommon for them to develop signs of pulmonary edema, but it can occur. Norepinephrine is given at 0.1 mics per kilo per minute. It can be increased by 0.1 mic per kilo per minute every 5 minutes, up to a total of 0.4 mics per kilo per minute. Alternative would be epinephrine, 2 to 10 mics per kilo per minute. And then Solumedrol, 2 milligram per kilo to the max adult dose of 125. And then alternative dexamethasone, 0.6 milligram per kilo. General considerations for shock, IV large bore. 2 lines are recommended for trauma, sepsis. 2 lines above the diaphragm are preferred. So the arm vein antecubital would be a preferred. Next would be humeral IO, but of course in pediatrics you can't do a humeral IO because they don't have an adequate humeral head. It's not formed completely yet. And then pediatric, an IO in tibia or femoral. Remember, tachycardia is the first sign of shock. Pulse pressure itself often narrows prior to a fall in systolic blood pressure. So in the type 2 hemorrhagic shocks, you often get a narrowing of your pulse pressure, which means that your systolic pressure stays in the normal range, but your diastolic pressure elevates so that a typical pressure would be like 110 over 90, which is a very narrow pulse pressure. That's only 20 pulse pressure. Changing level of consciousness is an important clue. Always document the time and amount of fluid you give. A quick and last thing on anaphylaxis. Remember, anaphylaxis, when you have true anaphylaxis, you really need to get epinephrine into the patient quickly. So, mild allergic reaction, generalized itching, hives, skin signs only. They have normal respiratory, normal blood pressure, normal heart rate, normal everything except skin signs, itching, hives. Benadryl, 1 milligram per kilo IV or IM if unable to start. Or it can even be given PO. Now with anaphylaxis, defined as dyspnea, wheezes, laryngospasm, angioedema, shock. If you're a BLS provider first, or if you have a difficulty getting an IV in the patient, i.e., the patient is in shock, it's going to be harder to start an IV because you're going to have to work at it a little bit. It's hard, a shocky person is often more difficult to get an IV in. So depending on the situation, if you're a BLS and you can only give it IM, or in a critical, I would like to start with 0.3 for an adult, 0.3 milligrams IM, or the epi auto injector. We don't use them in this state or in this county much because we train the BLS providers to draw up 0.3 milligram and give it IM. And then I'd like to see the epi infusion begun as soon as you get your IV established. The epi infusion start at 2 mics per minute for the adult and increase at 2 mics every minute as needed, titrating to clinical response. So difficult to get an IV in or a BLS provider first on scene. The epi goes in IM, and then as soon as you get the IV started, start the infusion. Then a fluid challenge for shock. Benadryl, 1 milligram per kilo. Notice that's the second IV drug. You don't do it the first. Albuterol for wheezes, that can be ongoing at the beginning. And Solumedrol 125 IV. An alternative would be dexamethasone. If there's a refractory shock, you can start a norepinephrine along with the epinephrine. In severe shocks, we often have more than one pressor agent running on the patient. But no matter what, if this is anaphylaxis, they have to get the epinephrine as soon as possible. Now, pediatrics, same exact thing. With a severe reaction, the epinephrine is at 0.01 milligram per kilo IM or 0.3, which is a max, or epi autoinjector, and the epinephrine infusion is begun as soon as you get your epi or you get your IV established. Okay, that is the end of this. Are there any questions burning that need to be answered now?
Nothing in this now.
Okay. One thing I want to mention, just this came up with an MPD meeting the other day, looking over some drug uses. Just a reminder that everyone should review the uses of droperidol. And droperidol is basically an antipsychotic medication, and it is not indicated for anxiety in and of itself. So if a person is upset, anxious, perhaps hyperventilating, but your impression is they are just anxious, it is not appropriate to use droperidol for them. We generally don't treat in the field. We don't generally treat anxiety. We basically try to talk the patient down. The problem is droperidol is such a good drug that a couple of patients have gotten this now for quote anxiety, and they literally the ER doc is unable to interview them because they're so sedated. And this is not appropriate. So just also a reminder that we've got two EMS personnel who are positive COVID in the last week, and so are on quarantine. So continue to use your prescribed PPE protocols for field work, and I would caution you to also continue to be hypervigilant when you're on your own time and in public settings, such as grocery stores, things like that. Just be cautious. It's much better than it was, but it hasn't gone away yet. But there's still mounting evidence that having the shots and the boosters will continue to provide you protection against severe illness, no matter what. Okay, well, thank you for your attention, and any questions, and drop me a line or Mark, and he'll get it to me. So be careful out there, and yes, about another 2 weeks, we'll have Dr. Gadbois with case reviews. So have a great rest of your day.
Right, thank you.